Well, hello and welcome to episode 3 of the UNC Children's Hospital podcast, coming to you from Chapel Hill, North Carolina. UNC Children's is a major referral center for children with complex conditions and consistently recognized as one of America's best children's hospitals. And for more information on UNC Children's Hospital, go to unchildrens.org. Our focus today is going to be on the area of pulmonology, cystic fibrosis, and other diseases of the lung within pediatrics. The first question is pretty basic. What is pulmonology? And our subject matter expert today is Dr. Stephanie Duggins Davis. Dr. Davis is chair of the Department of Pediatrics within the UNC School of Medicine and is physician-in-chief for UNC Children's Hospital, also known as North Carolina Children's Hospital. So thank you so much for joining us today, Dr. Davis. We're going to be discussing pulmonology, which I know is your area of specialty, and the disease cystic fibrosis. Now, I'm looking this up on the internet, as I want to do, and according to the internet, pulmonology is a branch of medicine that specializes in diagnosing and treating diseases of the lungs and other parts of the respiratory system. That might include asthma, emphysema, tuberculosis, and pneumonia, among others. So, Dr. Davis, tell us, if you're talking to a new acquaintance at a cookout, and they ask you, wait, so Stephanie, what do you do for a living? What do you tell them?
Yeah. Thanks, Phil. I'm glad to be here. So what I tell them, what do I do for a living? Well, I'm a pediatric pulmonologist, so I take care of children with lung and airway disease. So that would be children with diseases like asthma, more rare diseases like cystic fibrosis, or children who may come with persistent respiratory complaints. So children that may have chronic cough, recurrent wheeze, recurrent pneumonias. We also see children who have like noisy breathing issues. That is what is impacting their airway. So we evaluate children with airway problems as well. So anything that impacts the airway or the lungs. And we often will see children to help make diagnoses. So they may not present with a specific diagnosis like asthma, but they may present with symptoms such as noisy breathing, cough, or wheeze. So those are the kinds of children that I and others that are pulmonologists here at UNC, we see children from all over the state and actually beyond the state, because we have some centers that are really certain types of centers that are excellence really in seeing these types of children.
Now, how did you become interested in pulmonology? Was this something that you said, you knew going into medical school, that's what I want to do? Or did you find out while you were in medical school, or how did that sort of come about for you?
Yeah, that's a great question. So I knew I wanted to be a pediatrician at the age of 7. So I knew I wanted to take care of children. And when I was in medical school, I really thought I was going to do one of two things. I was going to be a general pediatrician. And I also did research in cancer. So I thought I was going to be a pediatric cancer specialist or a pediatric oncologist. When I started my residency training after medical school, I was exposed to caring for children with cystic fibrosis. And what I really liked about that was that I was caring for families that had a child suffering from a chronic illness. And you really developed a close relationship with the family and really helped the family and the child as they dealt with this very difficult illness. So I switched from potentially doing pediatric cancer and from doing general pediatrics to thinking, hey, I really want to be a pediatric pulmonologist. The other thing I did when I was a resident is I did research in pediatric pulmonology, and I measured lung function in babies, which is really hard. And I just loved the research. And so between loving the research and loving caring for these patients, that's when I decided as a second-year resident to do pediatric pulmonary.
So this was not in your first or second year. You were already in your residency when you decided, now where did you do your residency?
I did my residency at Riley Children's Hospital, which is in Indianapolis, Indiana. It's part of the Indiana University Health System. So it's a very big children's hospital right in the center of Indiana.
And so that was where you decided, you know what, pulmonology is, first of all, I want to work. But you said, let me back up. So you said when you were 7, you knew you wanted to be a pediatrician.
Right.
What was that? Did you just have a good relationship with some of your own doctors, or is it family members, or how did that come about?
Yeah, I have no family members in medicine at all. They're all lawyers or business people. So that was not because of a model in my family. I really loved seeing my pediatrician, and I really wanted to help people, and I really enjoyed, even at the age of 7, caring for younger children. So, you know, I did the whole camp counselor thing when I was older, did a lot of babysitting, and I just decided that this is what I really wanted to do.
Wow, that's amazing. 7 years old, you knew you wanted to be a doctor.
Yeah, it's in my doctor's
and basically, what kind of?
What now?
Wow, you figured you knew you wanted to be a doctor, but even more so, you knew you wanted to be a children's doctor. So that's amazing. And then and now look at you, you're running a children's hospital. Amazing. So let me ask you this, and you can feel free to not answer, but do you think? I know there's got to be differences, obviously, between adult and pediatric pulmonology. What are some of those differences, and is pediatric pulmonology more difficult just because you've got smaller patients and smaller body parts to worry about?
Yeah, that's a great question. I don't think it's necessarily more difficult, but I do think that we are able to intervene as pediatricians early and change the trajectory of disease into adulthood. And that's why I really love taking care of children. So if I identify disease, say, before the age of 5, so in cystic fibrosis is a perfect example. We know that now that we can diagnose it earlier, that into adulthood, these children, young adults, et cetera, do much better. So I really liked the opportunity to get in earlier, treat earlier, and change trajectory of disease. So that was a lot of the reasons why I really like pediatrics. Now it is different because an adult pulmonary, they take care of people with COPD, and we don't really do that type of care. And
Right.
we have teenagers who smoke, which is another thing as a pulmonologist, you can intervene early and prevent that. We're not really seeing the significant side effects that you may see from chronic smoking, such as COPD, that an endocrinologist may see. So it's very different.
Yep. Okay, and and I got some questions for you on that a little bit in a moment too. So let's switch gears for just a minute. Let's talk about a disease of the lungs that I think most people associate with children or adolescents, and that's cystic fibrosis, or also known as CF. So again, turning to the internet, definition there of cystic fibrosis is a disease that causes thick, sticky mucus to build up on the lungs, the digestive tract, and other areas of the body, and it's one of the most common chronic lung diseases in children and young adults. So what can you tell us about cystic fibrosis? It's genetic, isn't it?
Yes. Cystic fibrosis is genetic. It's autosomal recessive, which means you have to be born with the gene for cystic fibrosis from your mom and from your dad. So they may be carriers of those genes, and both of them have to be a carrier for you to actually have the actual disease, cystic fibrosis. We diagnose it now in all 50 states through newborn screening. So what happens is when they do the newborn screening, they check an enzyme called immunoreactive trypsinogen. And if it's elevated, then they send the blood off to look for the cystic fibrosis gene. And so that's what we do here in North Carolina, and that's how we make the diagnosis. You will pick up, nearly 98 to 99% of the children through newborn screening. Occasionally you don't, but the majority of the children are now picked up through newborn screening. Why is that important? Because this disease not only impacts the lungs, but it also impacts your nutrition. So children with cystic fibrosis have a problem with their pancreas, and then it makes it difficult for them to absorb food. So they can have difficulties with being malnourished, really small, failure to thrive, etc. So we pick up those children early, and then we can be more aggressive at treating them from a nutritional perspective. There are over 2,000 genes associated with cystic fibrosis. But most, there's certain ones that are very, very common. So here in North Carolina, we screen for over 100 of those genes, but there are a number of genes that can lead to cystic fibrosis. So it's located on the chromosome 7, and it basically, there's been a lot of work from a genetic perspective done for cystic fibrosis.
So, and you work with that. So you're saying 99% of the folks or children born, you can diagnose them at birth.
Right. I mean, 98 to 99%.
Right.
Right. And so what used to happen, actually, when I trained in the 1990s, the children would not be diagnosed in newborn screening. They would present with chronic respiratory infections, so chronic cough, pneumonias, and then they would present with failure to thrive. So they weren't growing well. And so you would do something called a sweat chloride test, which is a way to diagnose it. And that's how we would make the diagnosis. And we didn't because we didn't understand, we didn't have the newborn screening capability in at least the 2 states that I've practiced in. So now all 50 states have it, which is fantastic. And it's made a huge difference. In the 90s, we would see teenagers dying on the floor of cystic fibrosis. We hardly even admit children with cystic fibrosis to our inpatient floor anymore at UNC because the median age of survival is into the 50s. It is
into the 50s.
Unbelievable. It has been
wow.
A medical miracle what we have seen in regard to treatment for this disease over the last 2 to 3 decades. I mean, it has been amazing to see, and it's all been research and screening and picking up the disease early, and some of the new therapies that we have that have made a huge difference in how these children and adults do.
So this is genetic, and you've got all of this mucus that's building up inside of these babies, and later on, I would presume adolescents too. But how do you treat it? What's the treatment for cystic fibrosis?
Yeah, so the first thing is we'll start with the respiratory standpoint. So in cystic fibrosis, the defect is in something called the CFTR protein. And basically there is a problem with chloride secretion. And since the chloride secretion does not work adequately and impacts the cells that line your airway, what happens is you end up having a decrease in something called the airway surface liquid. It's basically a layer of fluid in your airway, okay? And what that does is that makes it really difficult to get any mucus out of your airways because this layer of fluid is decreased in patients with cystic fibrosis, this airway surface liquid. And then there's little cilia or hair-like cells you probably learned about in biology, and they don't beat like they're supposed to. And so you can't have what we call effective mucociliary clearance. So the mucus doesn't clear very well.
Productive, like a productive cough you hear about when it's during the regular cold season. But yeah, you can't tell a newborn, hey, you need to cough and get this out.
Exactly. So they can't get it out very effectively. So that escalator that helps to get it out, the cilia beating with the normal airway surface liquid, isn't there. So what happens is, because the chloride channel doesn't work effectively, and this airway surface liquid or fluid lining in it has impacted mucociliary clearance, impacting the mucus getting out of the airways, then you end up building mucus, and it starts in the very peripheral airways or distal airways, and you end up building mucus in those airways. And then what happens is you end up with a lot of inflammation, okay? So it's like a cycle.
Right.
Inflammation, then, inflammation, infection, you get infection you can't clear out. And then ultimately, with more and more mucus, you end up with airway damage, leading to something called bronchiectasis. And so that's essentially what happens in cystic fibrosis in the lungs. And how do you treat that? You treat the infection. So we have children and adults either cough in a cup to get sputum or swab the back of their throat to see what kind of bacteria they're growing. And we treat those different types of bacteria. So we're very aggressive at treating the bacteria with antibiotics. And we do that either on an outpatient perspective, sometimes we have to do it from an inpatient. And we also do something called airway clearance. And that's essentially like where you either do what we call chest physiotherapy, where you're going on the back of the child's back or front to kind of beat the mucus out, or they have vests, these therapeutic vests that people wear to help get the mucus out. Okay, those are two things you can do. The other thing you can do to help with the decreased fluid is something called hypertonic saline. So it's basically salt. It's just hypertonic salt. It's hypertonic saline, 7% hypertonic saline, and you inhale it through a nebulizer, and it helps to increase. Remember, I said that fluid layer is low. It helps to increase that fluid layer so that everything moves better. A lot of the work on hypertonic saline has been done here at UNC, and we've done a lot of work with patients with it. Yes, a lot of work.
Oh, that's great. Done.
So we have that as a potential therapy too. We also have a therapy called Dornase alpha that breaks the DNA links and helps to get mucus out as well. So those are like a lot of the therapies that were used for years. Now we have something called modulators. Okay, CFTR modulators.
Right.
It's a pill. Personalized, and it's medicine that helps based on your genetics. It helps that chloride channel work better. So, that is, it's amazing. So, for example, just today, Phil, this new modulator that's been out for the last 2, 3, 4 years for adults and adolescents just got approved for 2 to 5 year olds. It's called Trikafta.
Oh,
and what this does is it helps that chloride channel work effectively, so that is basically helping to treat the cystic fibrosis. And so the fact that we can now give that to 2 to 5 year olds is going to help prevent that chronic lung damage we just talked about. There are several different modulators. That's a whole lecture in itself, but it's the modulators, the aggressive treatment of lung infection, inflammation, and the diagnosis early during newborn screening that has made all the difference. And now the median age of survival is in the 50s. It is amazing. I mean, it's amazing. Amazing. So these modulators
I was
a miracle.
I actually was afraid to ask what the outlook was, because I had no idea. Some things I had seen didn't give that numbers that good. That's amazing.
Yeah, these modulators are amazing. They actually took adults that were on transplant list came off transplant list when they started taking the modulators.
Because their lungs were improved that much.
Because it was starting. Wow. It helped to treat that chloride channel defect. Yeah.
Wow. So would you say 30 years ago, what would have been the life expectancy of someone with cystic fibrosis? 30
years ago, which would have been like 1993. So that would have been right when I graduated from medical school. The median age of survival, the survival would have been like late teens, early 20s, somewhere in there.
Wow. And now it's 50. That's amazing.
It
is. And a lot of the work was done
a lot of the work has been done here. Right, yeah. Sorry, I can talk I know you don't have about that. Hey, one more thing.
I want you to. And
one more thing I want to tell you. The other thing
you
take is about 85% of children and adults take pancreatic enzymes, because remember I said their pancreas didn't work, and they have to take that to help absorb food. So that's really important too to know as a treatment.
Oh, okay. I know you don't have a lot of time, but I also know that you've done some work with another disease of the lungs, and I hope I don't butcher this too badly. Primary ciliary dyskinesia.
Correct.
So what is that, and what was the work you did on it?
Yes, I'll be very brief. That is also a rare disease. It is also a genetic disease, predominantly autosomal recessive, so you're born with it. And in that disease, you have a chronic bronchitis, pneumonia, and a lot of sinus disease. You actually have sinus disease and cystic fibrosis too, but a lot of chronic airway issues. You don't have the nutrition issues we just talked about in cystic fibrosis. And the work that I've done in it is really understanding, number one, how to diagnose it. Okay, so we've done a lot of work. And how do you make the diagnosis? How do we identify these patients? They weren't even being identified. It's a rare lung disease, but we're starting to better identify these patients through genetics, okay, and some other types of testing that we've done. And we've also shown that certain types of genetic defects is associated with worse symptoms. So if you have this specific type of gene, you're going to have worse symptoms, or if you have this specific type of gene, you may have better symptoms. This is a chronic respiratory illness. And it is really under-recognized by many physicians. I think now pediatric pulmonologists recognize it. We worked really hard to educate the pediatric pulmonary community about it. Adult pulmonologists are now recognizing it. But these kinds of patients go to the ear, nose, and throat clinic where they're having chronic sinus infections and it's not getting better. Those are the, and you really, and it really can cause a lot of morbidity. So when you're born with it and you literally have a chronic wet cough every single day, and it does not get better despite antibiotics, and you have a chronic rhinitis or runny nose, I mean, it's just every single day. And about half of these patients are born with what we call sinus inversus, where the organs are flipped to the other side. So if you see that, you have to think about that. And some of these children, about 80%, will be born term on time, but have to stay in the nursery for a long time because they end up on oxygen. Just like cystic fibrosis, they have trouble with the clearance. Same thing, that impaired mucosal. So a lot of what I've done with my team here is understand the disease, the pathogenesis of the disease, what it looks like, how to identify it, and the genetics.
Amazing. And so that one, just for folks that are listening, primary ciliary dyskinesia. One resource for that might be raredisesesnetwork.org. Is where you could find information from that. So if you're listening and you want to find more information online, www.raredisesesnetwork.org. Let me ask you before, in closing here, you were talking about teenagers and folks smoking. What's the best lung advice you could give parents to keep their children's lungs healthy?
That's a great question. Just tell them not to start smoking. If you have a healthy child and adolescent, smoking, I don't care. And, you know, a lot of teenagers think that smoking marijuana is better than smoking cigarettes. We need to really tell them, no, nope, that can also impact your lungs. E-cigarettes, all of that, it is not good for your lungs. We know how bad it can impact the airway. And bottom line, it will impact you later in life too. So, yeah.
I know. I lost my mom to it.
I
mean, it's COPD. I mean, and you know, I used to yell and scream was from the time I could speak. So, but it was a different generation. But I think, that's what I was hoping that's what you'd say. I knew you would. So, well, thank you so much. That's great. And I had another question there, but I don't even need to ask that one. It's like, what's the best advice you would give to adolescents to keep their lungs healthy? It's the same thing.
Right.
It's the same thing. And I guess is it true too? You really, once you stop, you start to recover. So it's not like you could ever really, you should ever say, oh well, I'm too old to do that. I mean, I can still.
No, you can still. I mean, stopping is always good. But what I would say, Phil, is
never start.
You get early damage. So you really don't want to be doing that. You don't want to be doing it, period. But if a parent needs to, and the myth of that smoking marijuana isn't as bad as smoking cigarettes is, I hear a lot of teenagers say that. We need to make sure they understand, no, it causes damage to your lungs too.
Yeah. I mean, you're lighting something on fire.
That's the fact it's illegal in North Carolina. But, that's what I'm saying. Is that
there's that too. Yeah. Well, thank you so much. That's all we've got time for today. Many thanks to our subject matter expert today, Dr. Stephanie Duggins Davis, Chair of the Department of Pediatrics with UNC School of Medicine and Physician-in-Chief for UNC Children's Hospitals. Thank you, Dr. Davis, and thank you to our audience for joining our podcast from UNC Children's. We hope you'll subscribe and join us for future shows. For more information on UNC Children's Hospital, go to uncchildren.org. And please subscribe to the UNC Children's podcast wherever you get your podcasts. Until next time, thank you so much.